So I named my talk Recent Developments in Neuro-Oncology. What we want to cover, and with a somewhat limited time, I'm going to skip through a couple of slides, but I still want to cover three issues. Provide an update on new treatment strategies for primary brain tumors. We will focus on the most common tumor that we face, glioblastoma, and look at some of the progress that has been made in targeted therapies and immunotherapy. Secondly, I want to outline a novel treatment strategy for CNS metastases. We'll focus here on meningeal carcinomatosis. And lastly, I want to show you a few, I want to introduce you to the spectrum of neurologic, non-metastatic complications of cancer. I have plenty of cases included in this presentation. I hope you enjoy this ride through neuro-oncology. So, primary brain tumors. This is what we mostly face. Glioblastoma multiforme, a highly aggressive neoplasm that can grow from invisible to golf ball size over the course of 3 months. Histopathologically, these tumors are hypercellular. They are pleomorphic. They form multinucleated giant cells. They are highly mitotically active and form primitive blood vessels. We only have two standard therapies, essentially, one for newly diagnosed disease, one for relapse disease. For newly diagnosed disease, we treat patients with concomitant radiochemotherapy and use an alkylator temozolomide along with it, followed by temozolomide consolidation. With that, we achieve a probability of survival at 2 years. Alkylator temozolomide along with it, followed by temozolomide consolidation. With that, we achieve a probability of survival at 2 years of about 27% in that 5 clinical trial. The FDA approved bevacizumab, the anti-VEGF antibody, based on preliminary results of 2 small phase 2 studies run at Duke and at the NCI, and you can tell that with a progression-free survival benefit of about 4 months, that this approval was mostly based on the desperate situation we faced treating these tumors, then with a remarkable effect. Along with those studies, we have learned that those patients carrying tumors that express the enzyme MGMT, methylguanine methyltransferase, fare much worse than those patients in whose tumors the enzyme is not expressed. That is reflected here by the orange curve, as opposed to patients with radiation only and who do express MGMT in the red curve. Novel treatment strategies are multifold. What we have particularly focused on over the last few years are immunotherapies. We have used, as many other groups obviously within the Cancer Center and beyond, strategies that target immune checkpoints, PD-1 and CTLA-4. We have been involved in clinical trials of nivolumab, an anti-PD-1 antibody, at various stages. The nomenclature is a little confusing, but I'll run you through it briefly. Checkmate 143 started out with a safety lead-in phase, and in that patients were treated with either nivolumab with ipilimumab in 2 different dose regimens. As a second step, then patients, after the safety lead-in was completed and a very similar safety profile was discovered as in other cancers, a phase 3 study was launched for relapsed glioblastoma, comparing nivolumab monotherapy with bevacizumab. We're eagerly awaiting the results of that study. It will be the first study, prospective study, reporting efficacy data on immune checkpoint inhibitor therapy for glioblastoma. Both these, all these treatment arms have been completed. What's currently open are 2 clinical trials for newly diagnosed glioblastoma. Checkmate 498 is a study for tumors, patients with tumors that have an unmethylated MGMT promoter. They are randomized to either receive nivolumab with radiation versus standard of care, temozolomide with radiation. Those patients who carry tumors with an MGMT methylated tumor, i.e. tumors that don't express MGMT, are randomized to either receive nivolumab with standard of care versus placebo with standard of care. That is a randomized phase 2 study. We've also enrolled patients, 3 patients, on Roy's study of atezolizumab for patients with metastatic or progressive solid tumors during the dose expansion phase. And we have enrolled 2 patients on Mario's study of using a combination of the CD27 antibody varlilimab with nivolumab for patients with advanced refractory solid tumors, also in the dose expansion cohort after determination of the MTD. I really only put in this slide to give you an idea as to how actively we have enrolled. This is a mix of all the patients we enrolled on immune checkpoint inhibitor therapies. Down here in the table you can see that 15 patients have died of 33 patients who were actually treated. Add to that probably another 10 patients who were randomized to the control arms in the respective studies. Obviously too early to tell, and this is obviously a very mixed population of patients with relapse disease and newly diagnosed disease. You can also see a cluster of patients who were just enrolled. Those are the patients on nivolumab, varlilimab, and the patients on the phase 1 study. So as I said, hopefully by ASCO or the Neuro-Oncology meeting later this year, we will have the data from the bevacizumab versus nivolumab study for relapsed glioblastoma. Now, are there any signals at this point that maybe a subpopulation, if not the general cohort, but if there's a subpopulation of patients with glioblastoma who will respond to immune checkpoint inhibitor therapy? Yes, there are. However, they are anecdotal at this point. There was a recent paper in JCO reporting on a meaningful and durable response of recurrent glioblastoma occurring in 2 children who carried a germline biallelic mismatch repair mutation that is obviously reminiscent of what has been recognized in other cancers, first and foremost colorectal cancer, that patients with Lynch syndrome mismatch repair deficiency are susceptible to immune checkpoint inhibitor therapy, probably because of the overwhelming neoantigen load that goes along with these mutations. We do see patients like that. Some of them have hereditary mismatch repair deficiency. This is a 72-year-old woman who we diagnosed a few years ago with a right temporal glioblastoma. This is the tumor at surgery. The pedigree was consistent with Lynch syndrome in terms of the distribution of cancers encountered. The histopathology was telling, what I went over with the first slide. The tumor displayed microsatellite instability, and a mutation was identified in the exon 13 of the MSH2 gene, a nonsense mutation creating a stop codon within that exon. There are cases of acquired DNA mismatch repair deficiency in glioblastoma patients. This is a recent patient, a young woman in her late 30s who was diagnosed with this butterfly glioblastoma. She was found to have a mutation in the polymerase epsilon gene on chromosome 12. It is a mutation that is within a hotspot for mutations known to generate a mutator phenotype, and as evidence for that really happened, exome sequencing also revealed nearly 10,000 other somatic variants within the tumor genome. Murat Gonel's group recently published a paper on how common this acquired DNA mismatch repair deficiency might be in glioblastoma. He looked at 720 sequenced exomes of patients with gliomas and identified 6 patients with high-grade gliomas who had excessive numbers of somatic mutations within it. He identified polymerase epsilon mutations within these patients. However, some of these patients also had MSH6 mutations at the same time. Further encouraging findings from an early paper from the Cancer Genome Atlas Research Network, in which they described exome sequencing on patients exposed to alkylating chemotherapy. Of 19 samples, 7 were actually found to be hypermutated. 4 had been treated with temozolomide, 3 had been treated with lomustine. So as a summary of where we stand with immune checkpoint inhibitor therapy, it's too early to tell where this is going. There's some encouraging result that may at least a subgroup of patients might be responsive. I didn't show you any waterfall plots because measurable responses have been scanned in this study. We've had many patients who, based on an initial flare, may it be a tumor progression or an inflammatory flare, had to be put on corticosteroids and were terminated from the trial, and then either on biopsy were found not to have a progressive tumor, or who lived more than a year after discontinuation of immune checkpoint inhibitor therapy. But this is anecdotal, and until we have a definitive trial published, we cannot tell whether this will be a success story for at least a part of our patient population. Let me review a few issues or progress from the targeted therapy field. The TCGA network identified and essentially confirmed what had been discovered previously based on more historic technologies, that most glioblastomas or glioblastoma-associated somatic mutations cluster within one of three or more than one of three growth-promoting pathways, either the receptor tyrosine kinase, RAS, PI3 kinase pathway, the P53 pathway, or the retinoblastoma pathway. On these diagrams, you see what's common in terms of amplification or oncogenic activation in red, and loss of function, tumor suppressor genes in blue, and the intensity of the color shows you what's most relevant. Based on exome sequencing results, we now distinguish between four different categories of glioblastoma: the proneural, neuroclassical, and mesenchymal type. I'm not going to go over the details of the molecular features, but you can see a few properties or mutations, alterations that stand out. Obviously, the classical type, almost invariably, these tumors have EGFR amplification. The classical type has also a good number of patients with a characteristic somatic mutant, EGFRV3. You see only a few of the proneural patients, and a handful of neural subtype patients have IDH1 mutations. I skipped now, but at the bottom you could see that CDKN2A mutations or loss also extremely common in glioblastoma. Let's look at strategies targeting the receptor tyrosine kinase pathway first. Glioblastoma does not contain kinase domain mutations, unfortunately, which would render them susceptible to the classical tyrosine kinase inhibitors such as erlotinib. This is a common mutation that, as mentioned, EGFRV3, a large deletion of the extracellular domain, but also point mutations occur in this region that may be targetable. A treatment strategy that showed some promise in a phase 2 study was an antibody targeting EGFRV3 in combination with bevacizumab. This vaccine led to a statistically significant survival benefit in the treatment group. Unfortunately, the monotherapy of the vaccine failed in a large phase 3 study. So one has to see if this can be confirmed in a larger study. One has to see if that study will even be launched in light of the disappointing results of the monotherapy study. A study spearheaded by Joe Contessa in radiation oncology uses a drug conjugate, an EGFR antibody that is specific to cells that have EGFR amplified or mutated, and that is linked to a cytotoxin. That is a phase 3 study that is currently ongoing here. Oops, I'm sorry, gotta go back. A few years ago, we treated a patient with an multi-tyrosine kinase inhibitor, vandetanib. This is the initial diagnosis, probably one of the smallest glioblastoma you're ever going to see. Here on perfusion scan, better visible than on the post-contrast MRI. She went into prolonged remission 2.5 years, but then relapsed. And when Murat in his lab sequenced this tumor, he identified an EGFR mutation, A289V, while copy numbers between primary and relapsed tumor looked fairly similar, the mutation was lost with the relapsed tumor, as you can see here in this table, and probably indicating that the tumor clone was under selection pressure, and ultimately clones survived that did not contain this mutation. Now, this was a retrospective finding. The mutation was not used for prospective treatment of this patient. Another example of targeted therapy, this is a non-glioblastoma case, but at least as a proof of principle that, yes, there's categories of tumors in neuro-oncology that we can treat with targeted therapies. This is a 21-year-old gentleman who had an MRI for a headache, was found to have a small non-specific lesion here close to the foramen of Monro. Also, it was noticed to have a very inconspicuous looking rash, but it was biopsied and was found to be adenoma sebaceum. Histology of this tumor was found to be consistent with subependymal giant cell astrocytoma. There is now medical therapy for these SEGAs using mTOR. mTOR is a negative regulator of the TSC1 and TSC2 are negative regulators of mTOR. And so in patients who, such as this patient who has tuberous sclerosis and a germline mutation in TSC1, it makes a lot of sense and has been proven to be beneficial to use an mTOR antagonist such as everolimus, temsirolimus, sirolimus are probably equally effective. Now, this patient was operated on because he bled into this tumor. He had underwent emergent surgery, had this tumor slowly grown over the years. He probably would have been a better candidate for medical therapy. On the RB signaling pathway, I already mentioned to you that there's plenty of patients who have somatic mutations of CDKN2A, homozygous deletions. We identified recently a patient with a germline deletion of CDKN2A, a young woman who previously had been diagnosed with melanoma. This is the gene locus of CDKN2A. Her mutation was a long stretch that encompassed other genes, CDKN2B and many of the interferon genes. Unfortunately, at this point, we don't have a clinical trial open using inhibitors of this pathway. There are clinical trials using or targeting the retinoblastoma pathway at various levels, but as of today, this is not something that can be offered to our patients. There may be epigenetic therapy for some tumors. The WHO has recognized now a distinct class of tumors, midline malignant gliomas that carry the K27M mutation in one of the histones, H3F3A protein. I think this is of interest to oncology in general, and soon will hopefully also be available to primary brain tumor patients. As a summary of these targeted therapies, as you can tell, we don't have incidence of targetable mutations in the 20-25% range as we see that in non-small cell lung cancer. Unfortunately, we don't. There's interesting targets. Our focus is on immunotherapy and EGFR-based, EGFR-targeted therapy, and hopefully within the next few years that will bear fruit. In terms of metastatic disease, I want to use one example to show that the list of exceptions of treating brain metastases with whole brain radiation is steadily growing. I'll show you a case of a 71-year-old woman with non-small cell lung cancer. This is her CT chest. This nodule was biopsied and was found to be is actually a lymph node was biopsied, a mediastinal lymph node that showed carcinoma cells staining for TTF, and identifying this as a primary lung cancer. The second stain that I showed you was cytokeratin. At the same time she was diagnosed with her lung cancer, she slowly developed progressive headache and confusion. MRI showed an ominous sign, linear enhancement along the folia of the cerebellum, a few punctate areas of enhancement in the anterior and posterior perforate substance indicative of carcinomatosis of the meninges that was diagnosed or confirmed cytopathologically in spinal fluid, and exome sequencing of the CSF revealed the same EGFR tyrosine kinase mutation as had been found in the primary tumor. She was started on erlotinib and had a remarkable response, not only of her systemic disease, but also complete resolution of her neurologic symptoms. She lived for 1.5 years before then her meningeal disease became resistant to systemic erlotinib therapy, and she passed away about 2 years after her initial diagnosis. Now, that doesn't sound like a great progress, but if, I'm sure you've seen plenty of your patients die from carcinomatosis within weeks to a couple of months. And it's a devastating death with alteration of neurologic function. I just skipped over the result, the MRI after erlotinib therapy, which showed complete radiographic resolution. And at the end, I want to take you through a few non-metastatic complications of cancer. This is a list of what we often encounter. We see vascular complications, prothrombotic or hemorrhagic, prothrombotic states, hemorrhagic diathesis. We see vasculitides in T-cell lymphoma patients. We see a lot of chemotherapy toxicity, immunologic complications such as paraneoplastic disorders. We see nutrition, the results of nutritional deficits. A very mundane one that we often see are compression neuropathies in patients who lost 20 pounds during the course of their chemotherapy. Let me start with one of the immunologic complications of paraneoplastic encephalomyelitis, one that is probably the most common affecting women, young women with gynecologic, oncologic issues, teratomas to be more specific. These young women often present with psychiatric symptoms, confusion, frank psychosis, and then develop the neurologic findings of an encephalomyelitis. They develop rather profound perioral dyskinesias. They develop dystonic limb movements. Ultimately, they go into respiratory failure and require prolonged treatment on a respirator. Early diagnosis is the key in these patients. They have antibodies targeting an NMDA receptor. The condition is reversible in about 75% of patients with eradication of the tumor and treatment of the immunologic condition with IVIG or other forms of immunosuppression. These patients have signs of encephalitis, inflammation here in the mesial temporal lobe. This is a PET scan just showing that there was decreased tracer uptake in the right temporal lobe, and this is the culprit, the underlying gynecologic neoplasm, a teratoma. These tumors can be anywhere, teratomas anywhere in the body can give rise to these syndromes. Second example of a non-metastatic complication, toxic metabolic encephalopathy. This is something of interest to you guys who treat breast cancer, gastrointestinal cancers, adolescents with leukemia. These patients with the specific syndrome called delayed leukoencephalopathy syndrome present with stroke-like symptoms, dysarthria, hemiparesis, often severe headaches. On MRI, they have stroke-like symptoms in that they're bright on diffusion-weighted imaging and dark on ADC maps. This is a completely benign syndrome as long as it's recognized and patients, the agent that elicited the reaction is withheld or at least decreased in dose. We don't know the exact cause, but without treatment other than simply stopping the chemotherapy, these patients have a full recovery. It's important to recognize the syndrome since many of these patients do undergo catheterization for vascular workup. This particular patient here has had colorectal cancer, and she was treated with FOLFOX6 and bevacizumab. She had a rather severe reaction systemically, and in that setting then suffered the neurologic syndrome. She was found to have a well-known polymorphism in the DPG gene, the dihydropyrimidine dehydrogenase gene. It's a splice site mutation that ultimately leads to deletion of exon 15 in the transcript. Again, reversible. The most important aspect here is to recognize the syndrome early. A couple of vascular complications. This is a patient with cerebral leukostasis syndrome in blast crisis from CML. You see multifocal hemorrhages. These patients are treated with leukapheresis, whole brain radiation, and exchange transfusions. An interesting recent case of a microangiopathy manifesting as alteration in mental status, confusion, progressing over 6 months. He was found to have a plasma cell dyscrasia with MGUS, and interestingly, treating the plasma cell dyscrasia led to substantial neurologic improvement. We suspect that the antibody the clone produced was vasculopathic. And I end with a cerebrovascular complication in the setting of lymphoma. Again, a clinical presentation similar to the patient I presented to you before, a microangiopathy evolving over the course of a year, 3 different time points showing small vessel infarctions in different vascular territories. Ultimately, after that year and many empiric treatments, this patient was diagnosed with intravascular lymphoma. You see here the lymphoma cells occluding a capillary. These cells are CD20 positive. This is a systemic disease that also affects muscle in this case and other organs outside the nervous system. A disease when readily diagnosed and treated with high-dose methotrexate that is very much reversible. So I hope you enjoyed the ride through neuro-oncology in 18 minutes. I think we're in terms of what we the most common neuro-oncologic issue we face, glioblastoma. There's reason for hope. I hope that within a year I can present to you data on the immune checkpoint inhibitor therapies, and hopefully they will be positive. And with that, I take a question or two, and I wish you all a happy new year.
So we have time for one question. I know people may have to run. Yep.
Joachim, could you comment on the issues of the blood-brain barrier, particularly in drug delivery, particularly to diffuse, disseminated tumor from the brain, which is so common early on in gliomas?
It is definitely a major issue for many therapies. Drug concepts that have worked for systemic cancers often fail in the brain because the drug does not sufficiently cross the blood-brain barrier. That is the case for some of the small molecule inhibitors. That's certainly the case for antibody-mediated treatments, EGFR antibody-mediated treatments that generally don't work in the brain. For therapies such as VEGF inhibitors or immunotherapies, it's